respected chair, colleagues and friends. So continuing with the prevention, we will be going to a common problem, that is CT coronary calcium scoring, which is now coming up. So we will start with a case scenario. A 49-year-old gentleman has come for a health checkup. He is very eager to know whether he will get an MI or not, because his friend has had a MI recently. He is not a diabetic. He is not having any family history of CAD. He is not a smoker. His BP is 130/84. Total cholesterol is 242. LDL cholesterol is 140 and HDL is 35. So what we do for prevention, we actually calculate the ASCVD risk, that is atherosclerotic cardiovascular disease risk of 10 years. This is basically taken from pooled cohort equations. Pooled cohort equations are actually taken from different areas. The first four are from US, European score is also there, Framingham CHD scores are also there. Everything together they have taken the scoring system for prevention of CAD. Pooled cohort equation, that is what it's called. So this is the table for that, the calculator for this, that is ASCVD risk estimator plus, which includes LDL cholesterol also. Earlier it was only a risk estimator which did not have a LDL cholesterol in that. So what do we do and whom do you see? It is basically for patients who are more than 40 years and less than 75 years. And LDL should be more than 70 and it should be less than 190 without diabetes. So with that you see the risk and then discuss about the prevention pattern. Diabetes, you don't see the risk factor at all, you have to treat. Family history of CAD, we have to treat. Familial hypercholesteremia, we have to treat. LDL more than 190, we have to treat. So excluding these patients, 40 to 75 years old, you see the risk factor, the score. So the scores are calculated like this: less than 5% is low risk, 5 to 7.5 more borderline risk, 7.5 to 20 intermediate risk, and more than 20 is high risk. And what we do the prevention strategies, starting of statins or lifestyle modification. The first and the last one is easy. The last one requires definite treatment. The first one does not require treatment. Whereas the intermediate groups, that's 5 to 7.5 and 7.5 to 20, requires some more additional things. Usually it is based on risk enhancers. That is, if the patient is having a CKD or an elevated lipoprotein little a, then you treat it with the statins. Otherwise, if these are also not there, then the latest suggestion is to do a calcium scoring. Now, how does it change it? You can see that in the first one here, the second column, you can see the first two, the lowest risk and the highest risk, there is no change at all. Whereas the intermediate risk group, you can see that if the calcium score is 0, then statin is not recommended. So based on this calcium score along with the ASCVD risk score, you can either reclassify these intermediate risk group patients to up or down. Now we will come to what is calcium score. How does calcium come into the plaque? We all know how does plaque develop. That is LDL cholesterol, ApoB containing cholesterol goes into the endothelium and then being engulfed by the macrophages becomes the form cells. I am not going to the details of that, and then it produces inflammation. So some factors like bone morphogenic protein, osteonectin and osteocalcin produces osteoblast producing cells inside the atherosclerotic cells and produces a calcium deposit in the atherosclerotic plaque. So what is calcium scoring? It measures the calcium in relation to the plaques. There are three types of scoring, that is Agatston scoring, volume scoring and mass scoring. The commonest one which is used is Agatston scoring. So what they do is, we see the plaque and the calcium, and the plaque area is multiplied by the calcium Hounsfield score divided by 100. And then each one is taken and then you add together and get the score. So in this case actually we have the anterior one is the RCA, that is measured as a Hounsfield of 305. So it will be 3 into plaque area 12. So that will be 36. And add together all the ones, you get the lowest one, 56. So this score is 56. Now how much calcium scoring we get? We can get from 0 to more than 1000. This is about individual calcium scoring. But what about the calcium score of a person in relation to the age, sex and the ethnicity? Calcium score of a patient who is 45-year-old male will not be the same as the calcium score of a female who is having the same age. Similarly, a white and black may have different calcium scores. So, in relation to that, MISA, that is multi-ethnic study of atherosclerosis, has made a calculator which includes age, gender and ethnicity also, inclusive of the including the calcium scoring. So with that, we get a percentile score, that is more than 75 percentile for age and sex, or less than 75%. Left one is better, the right one is you have to increase the risk of scoring. So after this, what we do is, in the intermediate risk group, if there is 0, then recalcify it into lower risk. And if it is more than 100 or more than 75 percentile, then higher risk. Now that is about the calcium scoring, which is in relation to the ASCVD risk score. Now we will see whether the calcium score itself can give you some risk prediction of future events. So calcium scoring can be divided into 5 stages from stage 0 to stage 4. Stage 0 will be 0 calcium score, no plaque at all, only lifestyle modifications required. Stage 1 will be 1 to 99 with a less than 75th percentile that requires LDL cholesterol goal of less than 100. Now stage 2 will be 100 to 299 or more than 75 percentile that requires more treatment with an LDL goal of less than 70. Now this one is very important, stage 3, there you have a calcium score of 300 above. In such a case, you have to give high intensity treatment to give a goal of less than 55. And also this has been shown in studies that this particular multinational confirmed registry, they actually what they did is they divided into 5 groups. One group with a patient who had an MI earlier, the others did not have an MI earlier. And those who did not have MI earlier, they are divided into different calcium scores. And what they have seen is those patients with more than 300 calcium score without MI and those patients who had an MI earlier had similar incidence of MACE, MI or any cause mortality. And so with that, the recommendation comes as to give aspirin also in those patients who have more than calcium score of 300. Now stage 4 is definitely more than 1000, it has to be treated as patients with multiple ASCVD events, high risk group. Now coming back to the first case which we have discussed. So in this case, if you do the ASCVD risk calculation, it will be 6.2. So what to do? If you do a calcium score and the score becomes 0, you don't treat with statins at all. If it comes above 100 or 75th percentile, you treat with the statins, and if the calcium score is more than 300, you consider aspirin also. Now what about repeat calcium scoring? 2 studies have gone into the details of that, MISA study and HNA study. Both of them showed that those patients who have a 0 score may go within 5 years to more than 0 score in around 20%. But what is more important is double 0, that is 5-year interval you have 0 calcium score in the CT scan. They have the lowest risk of ASCVD, that is 1.4%. So that is very important. So which all patients will do risk scoring again, calcium scoring again, that is with a calcium score of 0. You can do it from 3 to 7 years depending upon the risk of the patient. Now what are the other uses of CECT just other than the calcium scoring? Just another scenario, 43-year-old lady, no significant risk factors, atypical chest pain which is pricking type, not at all type of cardiac, but the TMT comes as positive and comes again and again with the atypical chest pain. So what will be the options? Give reassurance, do an invasive angiogram with its inherent complication risks, or a non-invasive CT angiogram. So in non-invasive CT angiogram, if you see in the meta-analysis and multiple studies, what we have seen is negative predictive value of CT angio is above 96%. That means if you have a negative CT, you can rule out a coronary artery disease and the symptoms is unlikely to be due to that. But if it is a positive CT, then the positive predictive value of that CT is not that good. Then we will have to confirm with the invasive angiogram. Now also the CT scan, the importance is if you do an invasive angiogram, we are seeing only the lumen. It's a lumenogram. Whereas a CT angiogram is a lumenogram plus a wall picture. So you can see the high risk plaque. The high-risk plaque is basically a thin cap fibroatheroma, that is thin cap of the plaque. So that can be that's the last slide, determined by, just the last slide, that can be determined by a low attenuation plaque or positive remodeling, that is increase in the size of the vessel, or spotty calcifications and the napkin line. So I will come to the last slide. So take home messages include calcium scoring restratifies in the intermediate risk group. Score of 300, aspirin has to be given. 00 calcium score at 5 years apart is got the lowest risk of 1.4% of ASCVD risk. Negative predictive value of CCTA is much more than 96% and it's very reliable in atypical chest pain group. And then thin cap fibrosarcoma, that is high risk plaque, can be identified by a CCTA. Thank you.